ابدأي يا دينا.
Okay, good evening everybody and welcome.
هنبدأ بالفيديو الأول بعد كده اوكي، يعني بعد ما نخلص الفيديو هنبدأ. اوكي.
Good evening, everybody, and welcome to our iHub episode. Tonight, we're going to discuss a challenging topic, which is cataract surgery in uveitis. Myself, Dina Baddar, with me as a co-moderator, Dr. Ahmed Shama from Alexandria University. Our speakers tonight are people with long expertise in surgery in general, in cataract surgery and in uveitis. We have with us Dr. Nihal Al Shakankiri from Alexandria University, Dr. Mahmoud Soliman from Cairo University, and Dr. Ramy Riad from Cairo University. It is just worth mentioning that Dr. Ramy Riad might be having some technical difficulties because he is currently in Beirut, in Lebanon, as a part of a Cairo University envoy to Lebanon as part of the relief efforts to the sister country. So welcome, my professors, and thank you for being with us.
Thank you very much
it's going to be
an invitation. Thank you, Dr. Shama. Thank you,
Thanks
Dina.
a lot, Dr. Mahmoud. It's our pleasure to have you here in our iHub. I remember always your father, your late father. He was a unique professor and unique teacher. You inherited everything from him, the good quality of lectures and the good quality of surgery, anterior and posterior segment surgery.
Thank you very much.
Dr. Nihal Al Shakankiri, thank you so much. We are very proud of you in Alexandria University, and we are very proud that you are here with us in our iHub.
Oh, thank you, sir. So I'm going to lead the way. First, I'm going to talk about how to manage a uveitis patient, especially if you're thinking about taking them to the OR, because the subject of managing uveitis might be outside the scope of this episode, but we're only going to tackle from a surgical point of view. So I don't do my own surgery, and this is what I'm going to be explaining through my talk. And that's why I'm asking the expertise of our panelists that they're going to share with us about all the touchy subjects, all the disputed areas in cataract surgery in uveitis. So I'm going to start my presentation. Can you all view it now?
Yes.
Okay, excellent. All right, so the uveitic population is a unique population in being younger and more surgically demanding and having two factors playing a part in forming cataract. That is the inflammation and the steroids. The incidence is as high as 78% in Fuchs iridocyclitis and also like 60% in pars planitis. And incidentally, these are two pathologies in which cataract surgery is usually promising with the good visual results. The issue is that we have little published data about the subject. Why? Because it's a chronic disease. The process, so the cataract surgery is an event in a long ongoing process that precedes the surgery and proceeds the surgery. The posterior segment is usually affected. We are used to short follow-up periods in regular cataract surgery, but not so much in uveitis. This is what I always tell patients: uveitis is a book. It's or even a chapter in the book, but it's not one disease. So it's a heterogeneous disease. Most cases are small; they carry small numbers in the studies or in the published data, and they're usually retrospective with few comparative studies by the big authorities like the MUST or the Sun. But other than that, they're usually retrospective chart reviews. But the one thing that is not controversial, and that we all agree, is that good control of inflammation before surgery is the key player in the success of the surgery. So this is my suggested algorithm. As I was just telling you, I don't do my own surgery. What I do is that when the patient presents, or what I would recommend is that when the patient presents, he or she is referred to a uveitis clinic, even if he or she is quiescent. Don't rush into surgery. You don't know what's happening in the posterior segment, and you don't know how long this patient has been quiescent for. Once the patient is referred to the uveitis clinic, I totally recommend that we look at all the data that the patient has, all the former workup, every single piece of paper, and also every investigation that the patient has to present. It's usually a tedious job, but we have to do it in order to understand the prognosis of the surgery. And then deciding on the time of the surgery. Now, I think this is up to the uveitis clinic. Then refer to surgery and doing the surgery. Now, my first question to the panelists: how often do you go through this algorithm? Let's start with Dr. Nihal.
Actually, what we do in Alexandria University, we work as a team. Concerning my own all the specialists and the pediatric rheumatologists are concerned with the major work, which is diagnosis first of the etiology, and then the preoperative management, and then they even decide when to go for the surgery. So I do the easiest part or the least part in this circle, a huge circle, and then they take again the patient even from one day after surgery treatment and continue observing the child for the risk of complications that are massive and will occur after surgery.
Okay, excellent. Dr. Soliman, how do you prefer to do uveitic cataracts?
Well, the cycle is nice. I do the cycle myself because
You have
work.
experience.
Yes, I work as a uveitis. We have a uveitis clinic as well, so I'm more or less aware and confident using the antimitotics and all the possible immune modulating drugs. So I do the job. I decide when the patient is ready, and then I do the surgery and I follow the patient. So I take a combo approach, which I believe we could give very good results at the end, I hope. But I agree 100%. I mean, this
Dr.
cycle,
Shama?
this is the best way.
I'm lucky enough, Dina, because you follow the patients and you prepare the patients for me with the medications. And it's very easy for me to go for surgery and then send back the patient for you to follow him. Thanks a lot.
Yeah. So I think we all agree. I don't know if Ramy, are you with us? Doesn't sound like Ramy can see us. Okay, so everything. Ramy, are you here? Oh, trouble with connection. Okay, again, Ramy is connecting from Lebanon, so he might have technical issues.
Ramy is back. So the internet in Beirut is on.
Great.
Hello everyone.
ازيك يا رامي؟
Hello, ازيك يا دكتور محمود؟ ازي حضرتك؟ ازيك دكتور
كيف
احمد؟
حالك؟ كيف حالك؟
تمام كله زي الفل.
كان السؤال what do you do before as a preparation for a case of uveitic cataract? What do you do before surgery and after surgery? Do you have a scheme or do you follow the patient yourself?
عشان we have Dina يعني at our practice Dina يعني she is the uveitis consultant. So we usually, whenever we have a uveitic patient, we refer to the uveitis department, and then they tell us, they tell us wait, they tell us you can proceed and do the surgery. We follow up the patient together until there is a enough period of quiescence, and then we go ahead and do the surgery.
All right. So I'm really glad that you can hear us, Ramy. And let's proceed. Now, inside the Uveitis clinic, it's a complicated and it's a long and tedious interview with the patient. We consult the patient to identify the etiology, and we prepare a plan. So we put the plan with the patient and with the surgeon so that they understand how we're thinking and what we're thinking. We usually write a lot of referral letters back and forth. We plan on the treatment of complications. We then once we reach quiescence, we send the patient out and then we monitor this quiescence. Okay, so just a couple of things before we proceed to surgery. Now, I want to tell the audience some clues if this cataract is uveitic. So an elderly patient can present with cataract and you're not sure if it's senile or uveitic. Once you see the posterior synechiae, once you see stromal iris atrophy that is not justified by trauma, this is probably herpetic, or you see anterior vitreous cells. So in a well-dilated eye, you look behind, with a slit beam, you look behind the lens and check if there are cells. Now, these cells, they do not denote activity, but they say that the patient has had an attack of uveitis before or iridocyclitis. Now, for an active patient, you might find keratic precipitates and you might find vitreous haze. So I totally, I recommend that you dim the light, you crank up the light you dim the light of the room, you crank up the light of the slit lamp, and look for the cells in the flare. The question is, why do we do the surgery and when to do the surgery on a uveitic patient? Now, the aim is to have a clear visual axis, right? Because the visual loss may be solely or largely due to cataract. So we need a clear visual axis. We need to detect posterior segment pathology to see relapses better. And also denser cataracts, they pose a risk in technical difficulties. Now, my question now to the panelists, how different is the lens, the nucleus in a young patient or an elderly patient or a uveitic patient? Let me start with Dr. Soliman.
If the patient has a long-standing uveitic episode, you might be sometimes facing hard cataracts, exceptionally in young patients. So you can have a patient who's 30 years, and then you are surprised by having a really hard nucleus, actually. But most of them, they develop posterior subcapsular cataracts, and this poses causes actually very severe visual loss and visual problems. It all depends on how long and the uveitic entity. I believe that patients with Behçet's, sometimes they develop the posterior subcapsular, and which is usually easy to tackle without a hard nucleus. Some patients who had a long, like patients with VKH, who had a long chronic type of inflammation, they develop a nuclear form, which is quite hard.
Oh, yeah, that's exactly my question. And so, Dr. Shama, which kind of patients is rubbery, or sometimes you face the rubbery gummy lens? Does that happen in uveitis?
I wanted to say that this term, the rubbery or gummy lens, it's you cannot divide easily. Also, there is some changes in the capsule itself. Sometimes in the chronic uveitis patient, you will have a tough capsule that you cannot manipulate easily as the regular ones. So there's a difference in the capsule and a difference in the nucleus. You cannot divide some nuclei easily.
So, Dr. Nihal, because your patients are in the pediatric age group, do you find any differences in the posterior capsule?
Well, actually, in everything, in the dilatation, the pupil, and I'm going to show this in the presentation, all these difficulties in the dilatation of the pupil, in epilenticulaar membranes, in the fibrosis and calcification of the anterior capsule and posterior capsule. So definitely there is a major difference between
Okay.
the uveitic and the congenital cases. And I'm
Okay,
sure.
and they're different. You can.
Pardon?
Do you see any difference between the congenital cataracts and the uveitic cataracts? Do you find in just in the nucleus or the consistency of the lens?
No, the majority of cases are soft.
They're young.
Dina, I want to ask that sometimes the cataracts are chalky white. They're chalky, not just rubbery. Sometimes they're like chalk.
Oh, okay. And how do you tackle that? Once you start grooving, how do you tackle that?
They're easier to crack, actually. They're easier to crack, but they are usually self-absorbed, so they move a lot within the lens capsule. So that's why they are tricky. But sometimes they're rubbery, as Dr. Shama said, where they don't crack easily. But other times they're chalky white and they're like chalk, so they crack easily. But the problem is that they're loose inside the bag.
Okay. Any tips and tricks when you're tackling that?
We do put a viscoelastic shell around the nucleus, all around the nucleus, so that it like cushions its movement.
Okay, excellent. All right, now we come to timing. When do we take the uveitis patients to the OR? So if the threshold for senile cataract is, patient with high visual demand who can see 6/6, but there's a difference in focus or in color saturation that is not satisfying patients, especially engineers and dentists. They usually want pristine vision. So if the threshold is low in senile, our threshold in uveitis is that high. So we wait until really the patient is especially if it's a hard to control uveitis, we wait until it's really time to get rid of this lens. This is exactly what I was saying. Now, focus really well before taking patient to the OR. These are active KPs. You do not want to open this eye. And also sometimes you find, I hope you can appreciate this minimal hypopion in the AC. So even if it's not as apparent as KPs, sometimes it is as subtle as a small hypopion. So please examine the patient really well, knowing that they're uveitis patients. Once the patient is quiescent, they're usually very hard patients, like these ones. Like you have a small pupil, obvious Bombay, quite a nucleus behind it, or a white lens with the remains of a posterior synechia happening behind it. So this is the algorithm again that I would recommend for anybody who's seeing or following up a uveitis patient. If you don't have somebody, a uveitis person in your practice, and you're doing the follow-up yourself. So if the patient is on treatment, keep the same regimen, monitor the patient at least monthly, bring the patient and look at them monthly. And once you're satisfied with quiescence, monitor them for 3 months and then take them to surgery. Patient is taking TNF inhibition, time the surgery around their infusion. Now, if the patient is not on treatment, you do the workup and the treatment like we said, and then monitor quiescence. But remember that we do not want to wait until the nucleus is hard. And although we did say that we have low threshold, but you have to keep a balance between taking the patient and ensuring the quiescence and the success of the surgery. Now, 3 months. 3 months is what we're looking at. 3 months under your care. You're looking at the patient at least once every 4 weeks. You're ensuring that the patient is quiescent for at least 3 months before you take them to the OR. So, can we twist this rule? Now, my question is definitely going to Dr. Nihal right now because she's usually stuck between amblyopia and cataract. Dr. Nihal, what do you do?
Concerning unilateral,
Sorry?
the question, Dina, your
The
question,
question is if you have a patient with active uveitis and dense cataract, but he or she's in the ablogenic age, you're stuck between amblyopia and risking opening an inflamed eye. Do
no,
you also wait for the 3 months or do you twist this rule?
no, you have to wait. Even if you have a very quiescent eye, and then before surgery, sometimes you tell me, no, there are cells and flares, so we defer again the surgery. So I have to have a completely quiet eye. Otherwise, the risk of complications are much more disastrous than the amblyopia.
Do we have to wait here for 3 months, or 1 month is enough of quiet eye? Because there is one paper saying that 1 month of quiet eye makes good results as 3 months. Only one paper says that. What's your opinion, Dr. Nihal?
There is quiet eyes for 3 months, and then we decide, or even 2 months, and then we decide the surgery, and then even 1 day before surgery, Dina finds a sort of inflammation there, cells, and I think in the eye is fine, but they tell me no, you have to defer. You have to defer. So at least not less than 2 or 3 months before going to surgery.
May I say something? I mean,
Yes, please.
What we're talking about the pediatric age group would develop the GIA. I mean, a month or 2 is not really a problem, or 3 months is not really a problem. It's not amblyogenic. What is really amblyogenic is a weak eye, which has been going on for some time, and the other eye is a good eye. So this is the amblyogenic status. But sometimes you have to go, even in the presence of inflammation. And that is when the patient has a pupillary block, and he has sometimes, in some of those patients, develop a severe pupillary block with severe glaucoma, and you have to interfere because the eye will never calm down because of the vicious circle of glaucoma but in these cases, you have to change the technique and you have to revert to a lensectomy technique. Because usually in these particular cases I'm talking about, the anterior segment is totally disrupted and you're not able to do a proper phaco. So yes, sometimes you need to go and you need to enter the eye even in the presence of inflammation. These are not, this is not the rule, but I mean, you don't have to wait and the eye is very, very, very angry and it cannot be solved, and wait for it to calm down. It will not. So sometimes surgery in these particular situations is the solution.
Dr. Soliman, besides the GIA, and I know Dr. Nihal is going to talk about this at length, the anterior chamber granuloma that we sometimes see in Egypt, sometimes they present with this granuloma and cataract. How do you tackle that?
We made a paper, a very nice study in our uveitis clinic about how to tackle this anterior segment granuloma. And we found excellent results when you go in and do an irrigation aspiration and actually aspirate the granuloma, because this granuloma keeps on, the inflammatory process goes on and on and on. And the study showed that within 24 hours to 48 hours, the inflammation subsides almost completely after you remove this granuloma by doing an irrigation aspiration. So in these anterior segment granulomas, the final solution is to wash the anterior chamber and aspirate this granuloma. Even if the eye is not quiet, by the way, because sometimes this is the only way to quieten the eye.
Okay. Ramy, are you with us?
Yes.
Would you wait, or if the eye is angry, what is your preferred way to do it? Would you wait, and would you go in? And if you're going to wait, would you implant or not?
No, I would wait definitely.
So if you prefer to go in,
I would wait definitely.
you would wait.
I would wait unless there's severe complication, as Dr. Mahmoud said. Then we would interfere, but I would never implant in such an angry eye. And you will see this in my presentation, the consequences of implanting in an angry eye.
All right, Dr. Shama, do you have any comments, any words?
I agree with Dr. Mahmoud Soliman. Sometimes we have to interfere in some patients.
All right. Okay. So this is one of the papers that was talking about the outcomes. It's a recent paper talking about the outcomes of cataract surgery in children with uveitis, and Dr. Shama was the one who pointed out this paper to me, in which they looked at 58 eyes, and like I was saying, it's a retrospective medical chart review. Again, first and foremost is GIA in the pediatric age groups, then comes Behçet's, VKH equally, and infections. They prefer to keep the patient aphakic in the presence of a cyclitic membrane, detected on UBM, or atrophy of the ciliary body, the presence of a vitreous membrane or opacity, or a patient who has experienced hypotony before. Now, these in such conditions, they prefer to keep the patient aphakic. However, the visual outcome in aphakic patients was poorer, but the authors attributed that to CME, pre-existing macular scar, or hypotony to be the causes of poor visual outcomes. Now, I think we will come to implantation, but we also need to understand, and this is Dr. Soliman's area of expertise, we need to talk about comorbidities in the eye. Dr. Soliman, how do you tackle a patient in which you're going to do cataract on? Maybe not a lot of vitreous inflammation, but you need to clear the vitreous as much as you can. Tell us about your experience, and if you want to share some cases, please go ahead.
Actually, most of the patients with chronic uveitis actually have vitreous membranes or vitreous haze, and sometimes the vitreous haze is quite significant. And even if you do the cataract surgery, the vision is still hampered, and the visual rehabilitation is not complete. So actually, I have the approach. My approach is rather quite aggressive, and I do almost in every case with chronic uveitis who develops a cataract, I do combined surgery. I do phaco in most of the cases, depending on the entity, because some patients or some entities I cannot implant. I do a phaco, implant the lens, and then I do a pars plana vitrectomy, clear the vitreous completely. If there are epiretinal membranes, I remove epiretinal membranes. Again, a frequent finding in these patients, epiretinal membranes. And then sometimes during the vitrectomy, I use triamcinolone, which is again an asset to relieve some of the triamcinolone in the eye. And I have found that this is an approach which gives me much better results than the approach I used to do previously, years ago, doing the phaco and then just injecting triamcinolone at the end of the surgery. Many of those patients, I had to go again later on and do a vitrectomy.
Okay, so that's for the autoimmune uveitis. And what about your experience and your vast experience, of course, in say infections like fungal infections?
Well,
Anything
fungal
different
infections.
in their surgeries?
Yeah, fungal infections. I mean, usually the vitreous is affected. Usually the cataract is there is no cataract because this is not a chronic inflammation. So you go inside and do a vitrectomy right away. If the patient, because sometimes the patients are of age, and they are diabetics at the age of 50 plus. So I do combined surgery anyway, because if you operate on a patient, do vitrectomy at the age of 50 or 55, sure, they're going to develop a cataract within few months later on. So I do combined surgery in these patients. But infections if you're talking about infections, I mean, candida, fungal endophthalmitis, endogenous fungal endophthalmitis, yes, you do. I have to do a vitrectomy. In most cases, if the age is the important factor to decide whether you combine surgery or not.
All right. Excellent. Any comments from the panelists? Dr. Ramy, I know you don't do retinal surgery. If you're doing a combined cataract and retinal surgery, how do you do it in your practice?
Well, we do if we're doing combined surgery, we do it with two consultants. The cataract refractive consultant does the phaco part, and then we transfer to the retina consultant that does the rest of the surgery.
Okay, and Dr. Nihal, what about the comorbidities like corneal band keratopathy chelation or glaucoma? How do you do it in your team?
Actually, it depends on the severity. For example, band keratopathy is associated with conjunctival cataract. If the visualization is good, we can go for the cataract surgery and defer the chelation for a later date. But sometimes we have to go for the chelation first and then go for the cataract surgery. So it depends upon the severity of the corneal affection.
And if a patient is glaucomatous and a non-responding glaucomatous patient, do you do a lensectomy first and wait and see how the pressure will be, or do you go for a combined surgery from the get-go in one setting?
Well, it depends upon concerning this glaucoma. Is it in cases of uveitis? Is it steroid-induced glaucoma, or it is glaucoma from the inflammation itself or the sequelae? Like, for example, when we have iridocorneal contact, iris bombae, occlusive papillae, and these types of secondary glaucomas. So we first perform the cataract surgery because in the majority of cases, the pressure can be controlled after lensectomy. And if it persists, then the glaucoma specialist would take over.
Okay. Dr. Shama, how do you do it in your practice? If a patient needs combined surgery?
No, I don't prefer to do combined surgery, glaucoma and cataract at the same time. If the glaucoma is prevailing, I prefer to tackle the glaucoma. If he has a significant cataract, I will go for cataract and then wait and do glaucoma surgery later on. Now I hate to do a combined surgery because the philosophy of the two surgeries are contradictory. You need a well-formed globe in cataract surgery after you finish, and you need a soft globe in cases of glaucoma surgery. And nowadays, I hate to do a combined surgery.
Okay, excellent. Do we have? Yeah, Dr. Soliman, go ahead.
I agree with Dr. Shama 100%. I mean, you really have to tackle the glaucoma first, which is usually the most difficult thing to do in uveitic patients. Cataract surgery is, I believe, it's an easy thing. Glaucoma is really a big problem in these patients. And may I add something there? Another horrible encounter in these patients, which is almost unsolvable, is hypotony. Hypotenuse eyes are really eyes with a huge problem. You really don't know what to do with them. And even if they develop a cataract, you really don't know. If they remove the cataract, it's very poor in the visual results. and the hypotony is almost uncurable.
Yeah.
I
Yes,
totally agree with you.
it has actually been tackled the question. Yeah. It's usually the
I
harder
agree.
thing to do. Okay, excellent. Do we have any questions from the audience, Dr. Shema? Because I can't see the comments on the comment box. Do you have any questions?
We will tell the questions at the conclusion of the talks, because I think we are running out of time.
Someone is asking Dr. Nihal to, because the sound is not very clear each time she talks. So, this is obvious for me as well. So,
Okay.
maybe speak closer.
Maybe it's an internet problem.
Okay. All right. So in order, for the interest of time, this is again the algorithm that we were talking about. And once the surgery is done, we refer back to Uveitis clinics for the patient to continue their treatment, and or to the pediatric ophthalmology clinic for visual rehabilitation. For preoperative care, we understand that you have to consent to talk to the patient about the general risks, and besides the risk of uveitis, the visual prognosis, the need for reading glasses, and I think everybody would agree that we don't do premium IOLs on uveitis patients. Do I have general agreement?
Agree, of course. Yes.
Yeah. Okay.
But you still can do toric IOLs in uveitic patients, but not multifocals.
Okay. All right. That's interesting. So allow for more time inside the OR, and the patient may need to understand about delayed visual recovery. The prognostic expectations, now Dr. Shema will talk about those, and it's time to take the patient to the OR. Anesthesia. Everybody does blocks. Does anybody do topical anesthesia on uveitis patients? Expectations, now Dr. Shema will talk about those, and it's time to take the patient to the OR. Anesthesia.
No topic in anesthesia for me.
You do blocks? Everybody does blocks, right?
Yes.
Yes.
I sometimes prefer general anesthesia in such patients, because when I manipulate the iris, it's usually painful, and I don't know how lengthy is the operation, and I feel more quite comfortable using the general anesthesia in younger age group.
Okay. So basically, Dr. Shema and Dr. Nihal, they do general, right?
Yes.
Okay. Now we talk about iris. Technical issues with iris. It's either a Bombay looking like that, in which the aqueous is trapped in the posterior chamber, or with the chronic inflammation, the iris is completely stuck down to the surface of the lens, and cannot move to the angle. Okay, iris management. Now this is where I'm going to ask you all to tell me your preferred practice. Let's start with Dr. Shema. How do you manage your iris?
I usually do manual dilatation of the iris after making the I tackle the synechia first, and then I try to remove any membrane that is encircling the pupillary border. After that, I find dilatation is much easier.
Okay. Do you use intracameral adrenaline?
Yeah, sure.
Okay. Dr. Soliman, how do you manage the iris?
Step by step. I do release of the synechiolysis. Sometimes it's a membrane. You can remove the membrane, helps you dilate the pupil. And then I do mechanical dilatation, try to dilate it. Most of the cases, you can have a mid-dilated pupil, particularly if you fill the chamber with visco. You have a mid-dilated and you can perform surgery. Occasionally, you have a really undilatable pupil, so I use iris retractors.
Okay. Dr. Nihal, how do you manage?
Well, sometimes there is a sort of an epilepticular membrane. When you remove this membrane, the pupil dilates, and sometimes not. So you have to go for iris refractors. I go for iris refractors, and then I complete surgery. It has an advantage that it's sort of a mechanical stretch to the iris. After surgery, the pupil is there's no fluid dilatation after surgery when you use this iris retractors.
Okay. Ramy, how often do you use hooks, Malugan ring,
Okay,
and what's your experience?
okay. There's a nice trick that I learned. Is just when the iris is totally adherent to the surface of the lens, just do a small iridectomy, and then you inject the viscoelastic from that iridectomy into the iris, and then with the retina, you start dissecting, not from the pupil outwards, but on the other side, from the outer direction inwards towards the pupil. It works
Yeah.
really well when the iris is totally adherent. It's a really nice trick that I learned.
Yeah, you mean do a PI, peripheral PI, where I'm pointing and sweep and do the sweeping motion. Yeah,
Yes,
that's
yes, yes.
how my mentor
From
used to do
forward
it in
to
the
within.
US.
Okay, it's really a nice thing that I've learned, and it really makes everything looks more natural. Well, I always say Malugan ring has saved our lives a lot, and it saves our coronaries. So it makes whenever there's an iris that is not dilatable, we just insert a Malugan ring, and it makes the surgery much easier.
Okay, and how costly is it for the patient, and or do you reuse it?
It is a costly. It is a very costly instrument, but because it's also supposed to be disposable. We reuse it, but it's disposable. But we don't charge the patient extra for using a Malugan ring. Actually, it's like a tool that the surgeon has, and he uses it whenever he needs because it's to save the surgeon, not to save the patient's eye.
All right, excellent. So this is the Malugan ring insertion. I'm just running past these. Okay, technique. Anterior or posterior segment surgeon. Do you do a lensectomy or do you do a phaco? I'll start with Dr. Nihal.
Of course, concerning me, I don't use phaco, and I never use phaco, whether for congenital cataract or for a pediatric uveitis eye. And for only anterior segment, so I go for complications after anterior uveitis or fluid induced, or if it after ingredient uveitis. So I approach totally anterior rectus and IOL in the back if I'm going to implant intraocular lens. If not, I'm going to limit the eye and take it, like for example in JIL.
Okay, excellent. Dr. Soliman, when do you go for lensectomy? You said when the eye is angry and the anatomy is distorted and you won't be implanting. And when do you do for phaco? When you go for phaco?
And I do for phaco, and the anterior segment is okay. There is no disruption of the anterior segment, except if I mean some patients the anterior chamber is formed. That is okay. But patients who have lost their anterior chamber, when you have the iris into the cornea, you have a almost total peripheral anterior synecdoche, and the anterior segment looks horrible. There's no way to do a phaco, so you do a lensectomy. But otherwise, if the anterior segment is okay, you do a straightforward phaco. Some patients with hypotony, severe hypotony, you're not able to do a phaco. You have to go and do a lensectomy. And by the way, these patients, if you do a lensectomy, even in the presence of hypotony, and you just prescribe them glasses, they go from hand motion to maybe 3-460, and they're so happy with this few meters vision.
Agreed, completely agreed. It does make a difference in the patient's life, especially if it's bilateral in VKH or GIA. It's a wonder. Dr.
Point
Shama.
something here, Dr. Dina.
Yes.
Dr. Mahmoud Soliman mentioned the hypotony. If you find a patient with seclusio pupillae or occlusio pupillae, and you find that the intraocular pressure of this patient is normal, be aware of this patient. You can expect that after surgery, he may be hypotenuse. And hypotony is something that, as mentioned, Dr. Mahmoud Soliman, is very dangerous. I have seen patients with uveitis that undergone cataract surgery and they developed hypotony and they developed papilledema and cystoid macular edema for a long time and shrinkage of the eye by time with the hypotony. This is very dangerous. But if you find a cyclitic membrane in the UBM, this is good because if you remove the cyclitic membrane, you may have a normal intraocular pressure after that.
And so what is your approach if you find the membrane? So people would be very wary to touch it. Do you have any tips for the membrane?
If I have anything in the posterior segment, I refer the patient to a posterior segment surgeon. If I find only cataract, I do it myself.
Okay. Ramy, which patients would you prefer a lensectomy on and which a phaco?
You know what? I learned when I first learned the cataract, the congenital cataract, I learned it as lensectomy. We usually used to do lensectomies all the time, but since I started working as a consultant, I never resort to lensectomies. I always prefer to do or to start or to try to do a phaco with a proper anterior rexus, posterior rexus, and that makes it much easier for me. I don't do lensectomies anymore.
Okay, which brings me actually to a question that I want to ask Dr. Mahmoud Soliman. Do you do posterior capsulorhexis and anterior vitrectomy on patients who've had iridocyclitis, a bit of vitreous inflammation behind the lens? Would you do that or would you prefer to keep it as such and then tackle with YAG later, the posterior capsule?
Yeah,
Dr. Mahmoud is not on his desk.
Yeah, it's not.
Oh, okay. All right. Then I'll defer the question to later. Yeah. So, like what we were saying, the prognostic factors, the phaco is not as good in the difficult situations like a JIA, Behçet's, and VKH. These are patients that you need to look at thoroughly before and really make sure that the inflammation is at bay for at least, like we said, 3 months before you go ahead and do the surgery. Okay, the age-old question: to implant or not to implant? Dr. Nihal, do you implant on all your patients?
Of course not. It is preferable not to implant, especially in cases of JIA. It is preferable to leave the eye aching. But sometimes you are forced to implant when in cases is unilateral cases, but we should expect complication that may occur.
Yes, but how do you rehabilitate if it's a because that's probably a question on everybody's mind. If it's a unilateral cataract, and you're only going to do one eye, how do you rehabilitate the patient? What is your plan usually?
Well, actually, I implant.
Okay,
There
if
is
it's
no
unilateral,
yes,
plan.
there is no role of contact lens. There is no role of aseptic spectacle, so I'm forced to implant. And we should expect the with this in the presentation, you nearly answered all the questions.
Okay, all right. Okay. So, so my questions to Dr. Shama, to implant or not to implant in an adult.
Now, I presented a poster in 2001. I think the poster was in the Askers, and it was a comparison between hydrophobic and hydrophilic IOLs in uveitic patients. And I found very good results with both hydrophobic and hydrophilic IOLs. Nowadays, I implant in most of my patients, but like Dr. Nihal said, patients like JIA I don't implant. I leave them aphakic.
Okay. And Ramy, if you don't have capsular integrity, would you implant or wait for a second, especially in a uveitis patient, or wait for a second setting?
If there's no proper capsular integrity,
Yes. Would you implant? Because, you
okay.
know, with uveitis, you then in the bag implantation, at least, if you don't.
It really depends because if I was advised not to implant, then I would definitely not implant. Or if I was advised by our uveitis team, but if they were okay with implantation, and I don't have enough capsule support, actually I would resort to a Yamani technique. I would implant
Okay,
using a
and
Yamani technique.
all right, so that's in a second setting, right?
May I say something in this respect?
Yes, sure. Yes, sure. Right now we were waiting for you.
Okay, sorry about that. Well,
Oh, it's
okay, let's have the adults and the pediatric group. The adults, the rule is to implant the lens in the bag, of course. This usually is the rule, and you can do that in most of the cases, except as I just mentioned, if the anterior segment is completely disrupted in very few entities, uveitic entities. Concerning the pediatric age group, which is a critical issue, I implant even in GIA patients, and I have a series of patients which I've been implanting and doing in the bag implantation, of course, and doing a combined vitrectomy with them. And the results were actually excellent on the long term. They might develop sometimes some posterior synecdoche on the lens, but usually, even if this happens, you can do a YAG membranectomy and disrupt the membrane. But the results with lens implantation in the GIA, if you don't implant the patients, those patients develop severe.
Sorry about that.
If the technique is proper and we overcome the psychological barrier of implanting lenses in these patients, I think you can have good results. Which type of lens? I believe that all lenses are the same, whether hydrophilic or hydrophobic. Even the patients I implanted with the silicone lenses years ago, they're doing well.
All right. So I'm going to leave the choice of IOL. Any comments on the choice of IOL? Okay. So all right.
Well,
so IOL implantation
in the bag.
Okay. Now steroids. Do you use the question to the panelists? Do you use periocular triamcinolone at the conclusion of surgery? Do you use intraocular triamcinolone? What is your experience with dexamethasone implant? Or do you do systemic tightening of control? Questions to everybody. Dr. Nihal.
Well, Dina, as I told you, I leave this to you to decide because for the systemic steroids, you decide the dose and you decide the timing and everything. And concerning the intraocular steroids, I don't use intraocular steroids because I told you I work on the complicated cataract after anterior uveitis. So I only give subtenon steroids.
Okay, Dr. Shama, what is your preferred practice in uveitic patients?
I prefer the subtenon injection. It's good for the systolic macular edema, and it's good for the uveitis itself.
That's what I believe, but I'll tell you about this recent study. Dr. Soliman, any preferred practice, any thing you want to tell us about the dexamethasone implant? Is Dr. Soliman with us?
Maybe his microphone is muted.
Okay, sorry about that. No, I don't. I'm not an advocate of the periocular triamcinolone as a post-op or a perioperative treatment. If I want to inject, I inject the intravitreal triamcinolone, or I can use the dexamethasone implants if the patient can afford that. And of course, with an umbrella of systemic, whether antimitotics or steroids. I raised the dose of systemic steroids periocularly, just before surgery and a couple of weeks after surgery.
So I agree with you, Dr. Soliman, is that the MUST trial, which was a major trial in 2016, they concluded that the substantial sustained control of inflammation in an eye, then if you do at that point that was the fluocinolone acetonide implant or the standard systemic therapy is equal. So if you tighten systemic control and if you give steroids perioperatively, you raise the dose of steroids just in the perioperative interim and then reduce according to inflammation afterwards, it's equal to the intraocular steroids. However, and that's for Dr. Shama, the point study changed everything in 2019, where they were talking about uveitic macular edema, and they concluded that injecting the steroids inside the eye is actually superior to periocular steroids. Although I still do periocular steroids on uveitic macular edema, and it has never failed me. Apparently, by the numbers, the intravitreal group wins. So that's something that might change our practice.
We actually did a study in our group, and we compared the triamcinolone as an intravitreal or subtenon in the management of cystoid macular edema in Behçet's patients, and the results were in favor of intravitreal. Although,
what's the percentage of glaucoma, Dr. Mahmoud, in your series?
30%. 30%, but they were manageable. No, only one patient only one patient of a group of 40 needed surgery for glaucoma.
Yeah. Yes, Dr. Shama, because when I was reading this study, the point study, they said for the modest increase in IOP, we advocate intraocular steroids. So that's their conclusion. Okay, here's an honorable mention. The Durezol, the difluprednate, is on the Egyptian market, and it works really well for uveitic macular edema. But, and I cannot stress this more, the dose is maximum 4 times a day. It does not use the prednisone acetate because the IOP spike is much more common, and it is twice as potent as difluprednate, and the IOP is quote unquote unpredictable and potentially dramatic. Anybody using difluprednate post-operative on uveitic patients that's available on the Egyptian market?
Dina, I'm afraid it's 10 o'clock now, and we didn't hear the 3 presentations.
All right, that's okay. My final words is no inflammatory treatment is too aggressive. So I will leave the floor now to Dr. Nihal. Do you want to talk about the pediatric age group?
Okay.
Dr. Nihal, can you hear me?
Yes.
Okay. Can you give us your insight into pediatric uveitic cataracts?
Okay. Is it obvious, the screen?
Yes.
Yes.
Okay. Cataract in children in these cases is due actually to intraocular inflammation as well as topical steroids to treat uveitis. Even with anatomically successful cataract surgery, these children are at high risk of complications, especially when implanting with the intraocular lens as dense IOL precipitates. You see precipitates on the IOL after surgery. It may be dense pigment deposits or cellular deposits. Sometimes it is not visually significant, but sometimes they are very dense and they become visually significant. Fibrinous reaction may occur or even inflammatory fibrotic membranes. Sometimes the IOL becomes cocooned and fibrosis like that, leading to amblyopia in these children and irreversible damage of the visual acuity, and sometimes complications are beyond repair. So surgery is contraindicated when there is a poor control of systemic condition, when there is poor control of uveitis, and there is cells in the anterior chamber before surgery. You have to control all this. And it is indicated only in children. There is a significant decrease in the visual acuity, and this visual acuity should be attributed to the cataract. Some cases like that, the visual acuity is not attributed to the density of the cataract. You have to search. Maybe it's a cystoid macular edema or glaucoma or whatever, but it has to be attributed to the density of the cataract, or you cannot see the fundus area or the macular area properly. You cannot assess the posterior segment, so you have to go for surgery in these cases. To implant or not implant, as we have just discussed, that the poor prognosis of IOLs in AIA, in cases where there is significant flare in the anterior chamber, when there is 360 degrees of posterior synechia, and whereas preoperative hypotony, or the younger the age, definitely the poorer the prognosis of IOL in these cases. The preoperative management, as you said, Dina, we have to have a quiet eye for 3 months. The oral steroids and the topical steroids should be controlled and should be administered by the uveitis specialists like Dina, anti-inflammatory eye drops, and in some cases we have to continue the immune suppressive drugs in aggressive forms of uveitis. I'm going to speak about the surgery, which is all the anterior segment surgery. The anterior chamber granuloma that you mentioned, Dina, we see it in many cases sometimes, or usually located in the lower part of the anterior chamber. Sometimes we see it rarely like that in the upper part. It may be variable in size, it may be small or large, and sometimes associated with cells with KPs on the back surface of the cornea. Sometimes it is circular, and sometimes it is irregular. And in many cases, it is associated with fibrovascular proliferation, and sometimes a granuloma together with a fibrovascular proliferation like that, associated with cells. And here with magnification, you see the cells and the fibrovascular proliferation in the anterior chamber. In these cases, they usually respond to topical steroids and they diminish in size. And sometimes they leave fibrosis in the anterior chamber that may not affect the position of the pupil. Sometimes they drag the pupil towards the fibrosis. In many cases, it becomes at the edge of the pupil or partially obstruct the pupil, or may involve the fibrosis becomes massive and cover half the pupil, or even occlude totally the visual axis. Sometimes they are associated with a peripheral cataract that is isolated and not connected to the fibrosis, and sometimes fibrosis become connected to the peripheral corneal opacities, and sometimes they present with total opacification of the lens or membranous cataract. Cataract in these cases, after controlling the inflammation and usually respond to topical steroids, the cataract is simple and easy, and usually they don't develop postoperative inflammation after surgery. And here an eye 1 year after surgery, and this is the fibrosis here in the anterior chamber, and the IOL is well centered and clear visual axis. And this is another eye 1 year after surgery, clear visual axis, and this is multiple sphincterotomies because the pupil was drawn towards the fibrosis. And this is another patient that had bilateral granulomas. The right eye had the cataract surgery, and this 1 year after cataract surgery, but the left eye didn't have significant cataract. So actually, it remained like that with the posterior synechia and the peripheral fibrosis in the anterior chamber. So in these cases, as Dr. Mahmoud said, we have to remove the anterior chamber granuloma in the acute stage to avoid seeing this terrible picture of fibrosis of the anterior chamber. Other types of cataract that's seen in children complicating uveitis is like that. For example, total cataract and usually present with fibrosis of the anterior capsule or fibrosis of the posterior capsule and variable degree of lenticular opacities and posterior synechia that here may involve half the pupil or circumferential here 360 degrees posterior synechia, and sometimes epilenticular membranes and a fibrosis in front of the lens. And we see a variable degree of corneal affection or the band keratopathies that may be mild or may be severe, as in this case, and may be combined together, cataract together with band keratopathies. And here both are severe band keratopathy and significant cataract. And sometimes we see even iridocorneal adhesions and kerato adhesions between the iris and the cornea and total posterior synechia and iris bombay, as here complicated cataract after avoked Koyanagi Harada. Can you see the poliosis here of the lashes? So when we go for surgery after controlling the inflammation, usually the pupils are undilatable like that. In cases of JII, as I told you, in cases of bilateral cases, we prefer to go to surgery without IOL implantation. And I prefer to go through corneal approach. I don't like to go posteriorly. You want to preserve the sclera, the conjunctiva. I don't want to go for a fibrosis because you may need the conjunctiva to be healthy, maybe for future trabeculectomies in these cases. So we go for clear corneal incision using MVR knife 20 gauge. And then we relieve the epilenticular membrane, and there is usually epilenticular membrane that may be cut by scissors to dilate the pupil. And then we go for the rexes, and it should be not less than 5 millimeter or even more, or maybe 6 millimeter. I remove the totally remove the posterior capsule, perform vitrectomy, and I go to perform a peripheral iridectomy. And here again, vitrectomy, and at the conclusion of surgery, you close these two tiny ones. It's a very simple surgery. So as I told you, we take the easiest part in management of uveitis. This is another case, MVR knife, 2 corneal wounds, and after pupillary dilatation, anterior rexis, and then we remove the posterior capsule, perform peripheral iridectomy, complete the vitrectomy, and here at conclusion of surgery. This is a knife with more complications. There is iridocorneal contact here, and there is band keratopathy, and here at conclusion of surgery. Here, extensive epilenticular membrane, and again, iridocorneal contact. And sometimes you see bleeding after removing the epilenticular membrane, and here vitrectomy, and at conclusion of surgery. In cases where we wish to implant, I start by the side port first, and then inject the viscoelastic, and then go for the all clear corneal incisions. Relieve the synechia from the side ports or from the main one. Here, after pupillary dilatation, in these cases, we perform the anterior capsulorhexis, and it should be 5. Not more, not less. And then we go for the posterior capsulorhexis and anterior vitrectomy. And in these cases, again, the posterior capsulorhexis should be exactly 4 in order to inject the IOL in between the 2 rexes. And it's a must to implant IOL inside the capsule bag, because the IOL, it acts like a foreign body, and you don't want to touch the back surface of the iris, not to increase the risk of cystoid macular edema. This is another case with band keratopathy and posterior technique. However, we use iris retractor in these cases, and here, as you see, there is total fibrosis of the anterior capsule. In these cases, we have to go for rexes with scissors, and here after irrigation aspiration, the posterior capsulorhexis, and it is possible to implant the intraocular lens, again a must, even if the anterior capsule is fibrotic like that, inside the capsular bag. And here at conclusion of surgery, This is before and at conclusion of surgery. And as I told you that the iris retractor make a sort of mechanical dilatation of the pupil. This is another eye with band keratopathy and complicated cataract and epilenticular membrane. We hold the epilenticular membrane and cut it with a micro scissors. However, again, the pupil is undilatable. We use here again the iris retractors, and there is partial fibrosis, patchy fibrosis of the anterior capsule, which is very common in cases of complicated cataract. We penetrated with an MVR knife and again with a micro scissors to perform a 5 millimeter or 4 millimeter opening. And here irrigation aspiration. There is opacification even in the posterior capsule, which we commonly see. And again, vitrectomy, posterior axis and vitrectomy, and injection of the IOL inside the capsular bag, despite having a fibrotic anterior capsule. Again, if you will not implant inside the capsular bag, it's going to lead to drastic complications after surgery, here at conclusion of surgery, and this is before and at conclusion of surgery. In cases of complicated or cases of cataract after here, intermediate uveitis, usually it's very simple when we work as a team and there is a good control of the uveitis. It looks like a very simple case of pediatric cataract, 5 millimeter rexus anterior and 4 millimeter posterior rexus, vitrectomy and implantation inside the capsular bag. It looks like a simple case of congenital cataract. And this is the case of uveitic, actually it's a steroid-induced cataract. This is the anterior rexus, and after irrigation aspiration, I see many cases like that with fibrosis of the posterior capsule, here with magnification. But the posterior capsule in these cases is soft. You can make the posterior rexus in the conventional way by hooking of the posterior capsule, tenting, and then tearing into a triangular tear, and then injection of viscoelastic into the Berger space. And then we can perform the posterior rexus easily, like a simple case of congenital cataract, despite having a fibrotic posterior capsule, and anterior vitrectomy, and the IOL can be placed inside the capsular bag here with magnification. The fibrotic posterior capsule, but we have an ideal 4 millimeter posterior rexus. This is an eye with fibrosis 1 year after surgery with clear visual axis. And this is an eye with it's a severe case with complicated cataract, total posterior synechia, iris bombay, and you see here at the edge, iridocorneal contact and band keratopathy. Here, a few weeks after surgery, and still with the band keratopathy. And here at the final result, 1 year after surgery, you have a clear cornea because she made a chelation. We have a deep anterior chamber, clear visual axis, no sign of inflammation, and the pressure was controlled. Here, this is another case. Sometimes the band keratopathy is severe together with the cataract. We go for the cataract surgery sometimes in the presence of the band keratopathy, as here a few weeks after surgery, and here an eye 1 year after surgery with no signs of inflammation. And this case was referred to us with a severe band keratopathy, and actually there was a recurrence in the corneal opacity and secondary glaucoma and iris bombay and posterior synechia. In these cases, we start with the cataract. Unfortunately enough, here, few weeks after surgery, deep anterior chamber, no signs of inflammation, and the pressure was controlled only by the cataract surgery. And finally, this case, when we work as a team again, this case, you will not believe it. This is after a uveitis, intermediate uveitis, 1 year after surgery. It looks like a congenital or a traumatic case. Multi-piece intraocular lens between the anterior and posterior rexes, and this is the other eye, single-piece intraocular lens between the anterior and posterior rexes, and no signs of inflammation. A final message: when cases are referred to you like that with a complicated cataract and with or without band keratopathy, please go for UBM, because sometimes, like this case was referred to us as a complicated cataract, but actually when we did her a UBM, we found that the lens is crystal clear. earlier, and this is not a complicated cataract, it's a sort of epilenticular membrane. So in these cases, we can remove the membrane easily and hold it with a forceps and a micro scissors, and here at conclusion of surgery. And I, 1 year after surgery, no need to go for a lensectomy, and we had a beautiful crystal clear lens after removal of the epilenticular membrane. And finally, to conclude, to perform a successful pediatric cataract surgery in uveitic eye needs a teamwork of a uveitis specialist, a pediatric rheumatologist, and a pediatric cataract surgeon. And it's only not, the success is not only related to a successful surgery, but actually to this teamwork. They have to go together as a team, and there should be a good control of the systemic and eye inflammation. And please, you have to go for a preoperative UVM to confirm that this is a complicated cataract and not an epilenticular membrane, and pre and post-operative medication with strict observation by the uveitis specialist in order to have a successful cataract surgery. And thank you very much for your kind attention.
Excellent presentation, Dr. Nihal, as usual. Have you ever encountered a cocoon membrane in one of your series?
Yes, that was 3 years ago, before working all of us as a team, and it was in a case of GIA that had IOL implantation.
What can you do for such a patient if you encounter a cocoon membrane?
If the inflammation is controlled systemically, and the rheumatologist say that the systemic condition is fine concerning the GIA, and concerning the eye inflammation is controlled for at least 3 months, and everything is fine, and there is no hypotony, I would go for only anterior and posterior membrane in front and behind the intraocular lens. We can go for surgical intervention to remove the membranes. Otherwise, if there is a posterior segment problem, I would not go for anything. If there is a hypotony, I would not go for anything.
Where is Dina?
She had a power cut. She's trying to reconnect.
So, Dr. Mahmoud Soliman, are you ready for your presentation?
Mahmoud, you're mute again. You're on mute.
Actually, yeah, thank you very much, Dr. Nihal, for an excellent presentation. Excellent, as usual. Yeah, I'm going to tackle some of your questions, Dr. Shama. Dr. Ahmed asked about the cocoon from some of the patients, which I'm going to tackle. So I'm going to go, shall I go to my presentation?
Sure. Go ahead, Dr. Mahmoud.
We have a question asking about prostaglandin eye drops before cataract surgery.
طيب احنا
رامي،
هنخلي الأسئلة. خلي الأسئلة بعد البرزنتيشن رامي.
Okay.
Can I start? Do you see my presentation now?
عشان نقدر نخلص في الوقت.
Yes, you see the
Okay, so well, we've heard a lot about what's going to do, what we're going to do to prepare the patient, and now I think the decision for the surgery and the type of the surgery relies on the team, and it's not a matter of just doing the surgery. It's to choose the technique. Whether you're going to do just phacoemulsification with an IOL, yes or no. This is a critical decision. As I just mentioned earlier, use as a routine IOL, except in very specific situations. So let's talk about the techniques, different techniques. This is the typical uveitic patient, doesn't dilate. This is what we call the rubbery lens because it's a chronic, long-standing uveitis. The lens can be very hard. This is what I used to do in the early days, just at the end of surgery, do an intravitreal triamcinolone. I realized that with time, these patients do need vitrectomy because the vitreous is not clear, and you need to do a vitrectomy to clear the vitreous because this is really hampering proper visual rehabilitation. So I reverted to combined phaco with an IOL implantation and vitrectomy. And this is in most opaque media, pan-uveitis, particularly if the patient has an epiretinal membrane. And this is a typical patient here. This is a patient with posterior synecdoche. You try to sever the synecdoche, try to mechanically dilate the pupil. Still, the pupil is undilatable. The solution, which is easy, just go in and place your iris hooks, and you have well dilated or though rectangular pupil. Usually the phaco is straightforward. This is again one of those patients with a hard cataract because of long-standing chronic uveitis, as you can see from the anterior segment. Usually the phaco is straightforward. You really need to do a proper capsular rhexis. This is important. And the phaco is no problem. Skip that. Okay, this is end of the surgery. The phaco, the lens is in place in the bag. You go in with your vitrectomy instruments. You do now with the 23 gauge and the 25 gauge trokers. It's easy access to the posterior segment. I usually use a four-port vitrectomy with the chandeliers, providing excellent view. I can do a waving. I indent myself and remove the vitreous. This particular patient, this was a patient with a VKH with a chronic uveitis, and use the triamcinolone. You can leave the triamcinolone, which is an asset at the end of the surgery. So this patient had a combined phaco with vitrectomy. Another patient, this is a diabetic, this is a Behçet's patient, and the anterior segment is more or less okay. You do a straightforward phaco, implant the lens, and in a moment you are going to see what I mean by doing vitrectomy to clear the vitreous cavity. This patient is a Behçet's patient, and the vitreous is so turbid, as you can see here. The vitreous is so turbid that I really doubt that the patient will feel any improvement in vision if I just remove the cataract. In this patient as well, you see that the occlusive vasculitis, and this was a single-eyed patient who actually did well after surgery, although with time the procedure or the process of Behçet's inflammation ended up with extremely poor vision. When you do a proper pars plana vitrectomy, you're able to remove epiretinal membranes and leave the patient with triamcinolone. Okay, this is a GIA patient, and this is how I do my patients now. I have a cohort of GIA patients. Most of them, you really need to use the iris refractors, which is it should be accessible, which should be available at the operating room at any time. And let's go forward. When you put the iris refractors in place, the lens is accessible. You do your proper capsular rhexis, and you do a phaco aspiration, and which is easy. This is an easy procedure. when you remove the lens, you're faced with this yellow reflex. You plant the lens in the bag, place it properly in the bag, and I hope you can see that the red reflex is not the red reflex, it's a yellow reflex. Why is that? Because the vitreous is so turbid and the vitreous is so hazy because of the inflammatory reaction. Make sure that the lens is in the bag, manipulate the lens properly, and then in you go. This is the vitreous, very turbid vitreous, very turbid. When you remove the vitreous in these patients, you really clear the visual axis, and even if the patient develops another sort of inflammatory process, the vitreous cavity, which is now fluid, clears very quickly. I leave the eye with triamcinolone at the end of surgery, and in this patient, I realized when I removed the posterior hyaloid, this patient had a small break, which you can do laser. This is the end of surgery, and this patient, she did both eyes, and she's being followed for years now, and the visual is 0.5 in one and 0.6 in the other eye. Okay, sometimes combined surgery, you have to do a lensectomy, and this is, as I mentioned before, a disrupted anterior uveitis, and in childhood uveitis, other than the patients I've shown, some with a severe disruption of the anterior segment. And these are some of the patients here. This is a patient where the iris is actually almost adherent to the cornea, and the patient has posterior synecdoche. You do a combination of anterior approach and the posterior approach. You remove the lens matter, and you can see here, which is always the case, a very turbid vitreous, which needs to be removed. Otherwise, the patient is not really visually rehabilitated. Particular patients, you leave the patient aphakic, place the patient prescribed glasses, and they do quite well. Another patient here, this is a patient with anterior segment granuloma, which has taken place in the lens and in the ciliary body, which is a strange place. Again, the anterior segment is disrupted. I really cannot do a phaco, so you need to go in a combination of anterior and then posterior approach. You might have some bleeding because of the granulation tissue. As you see here, there is a granuloma here taking place in occupying the lens and the ciliary body. So you need to clean, and inside you need to clean the vitreous membranes here, which needs to be cleared. Epiretinal membrane, which will be removed, small epiretinal membrane. And in this patient, he had a small break. You can do laser and the patient did actually quite well later on. All right. Sometimes, like this patient with a VKH, again, the anterior segment was disrupted. You need to do a lensectomy and clean the visual axis properly. And in these patients, you need to also remove all the capsular remnants in order to leave the eye or leave the visual axis with a very clean, clean visual axis. Okay, so there are difficulties when you're operating on these patients. As we mentioned, the preoperative control of inflammation, corneal opacities, you can chelate them. Adhesions are sometimes quite difficult, but manageable. Combined surgery is often required. And as I mentioned, the enemy, our enemy, is not glaucoma or adhesions. Our enemy is hypotony. Post-operative course, we mentioned that you have to use all your armamentarium, and still you get complications. What are the complications faced? You can get a flare of inflammation, not very common these days with all your armamentarium, but again, you can have a hypotony. So you start the patient, and the patient is already the tension, the intraocular pressure is okay, but some patients develop a post-operative hypotony, which can persist for a couple of weeks, and it is really scary. These patients, I increase their level of systemic steroids, and this does the job in most of the cases. IOL deposits are not uncommon. Capsular opacification, phimosis. Sometimes the phimosis takes place, and the lens bag becomes decentered, and this with years it can end up with complete dislocation. IOL decentration, cocoon formation, as Dr. Ahmed mentioned, is again something which can happen. Poor visual prognosis or the recovery due to the affection of the macula or the optic nerve, or a widespread chorioretinal atrophy. This is one of the patients which I had to operate. This is not my case. This was a patient who actually had a lens implanted in the sulcus. And you can see how much the anterior segment and the eye is disrupted. And not only that, he had a very dense posterior capsular opacification, and the anterior segment is completely disrupted. This is what you mean, Dr. Ahmed. This is what ends up when a patient gets not a proper surgery. This is a GIA patient who had a lens implanted without vitrectomy, I believe, and she came to me like that. Both eyes had the same picture, and a total corneal opacity, a retrocorneal membrane, and you can see this cocoon. The lens is engulfed in an amalgam of fibrous tissue and encroaching on the iris, a very complex cocktail of tissue, which is really very weird. Again, after you remove all this tissue, this is the lens here, and this is the capsular bag. So you remove the lens. This is a hydrophilic acrylic. This is the capsular bag. You remove the capsular bag. You do an anterior vitrectomy, and then you place your graft. After cleaning all the anterior segment, you remove the iris. You remove the fibrous tissue completely. You remove totally the iris. This is the only thing, the only chance for the patient to actually have some vision. This patient.
Dr. Soliman has disconnected.
Connection, yes.
Okay. Dr. Shama, do you want to start your talk while we wait?
We will start Ramy's talk because we ran out of time. Ramy, are you ready?
Yes, I'm ready.
Yes.
I'm going to be very quick. Dr. Ahmed, thank you for the invitation, and I hope it shows well. I will have my presentation myself, so please stop the sharing.
Okay.
Okay. Can you see it now? Can you see the presentation?
It's loading. Yes.
Okay. So I'm not going to bore you with a long presentation. It is just a few cases. So this is the case of bilateral uveitic cataract in a child with GIA. Female patient, 9 years old, with history of foggy vision for 2 years, and not able to be able to do her daily life, affected in daily life and school. Her best corrected visual acuity upon presentation was 50 centimeters in the right eye and 160 in the left eye. Very dense lens opacity with heavily pigmented membranes, a lot of flare and cells. No adequate fundus view, so we referred her to the uveitis unit, and they diagnosed her with GIA. She took treatment in conjunction with her immunologist, and she achieved quiescence. And then, however, the visual acuity was still 0.05 in each eye, and she could not perform her daily life or school well. So our uveitis consultant requested the cataract extraction with aphakia. This was a case before that we have done, similar case, diagnosed with GIA, but we implanted this patient, and the post-operative course showed aggressive inflammation, did not respond well to medical treatment, and ended up in a lost eye. So we decided not to implant this time. This is the video of the first eye. So we start by trying to find a plane to start our dissection with a cannula of the viscoelastic first, and then, if it's not possible, with the blunt spatula. Once we have a plane to dissect, it is a little bit easier to find what we are looking for. So here we could find the plane. If you see, there is a membrane, and this membrane is the one keeping the pupil from enlarging. I prefer using the capsulorhexis forceps to dissect this membrane. Sometimes it's quite adherent. It needs to pull. You have to be very careful when pulling because it might induce an iridodialysis. But if you are gentle enough, you can remove this membrane, as you can see here, and not cause any other damage. Once the membrane is removed, just using the viscoelastic, you can achieve an adequate size pupil to start your capsulorhexis. Regular capsulorhexis using the rhexis forceps. Here we have to be more careful when doing our rhexis because the capsule might act funny, not like the regular capsules we're used to. Capsulorhexis was done, and this is like a soft lens. So a simple irrigation aspiration using the bimanual technique is sufficient to remove this lens. Whenever I can do IA, I prefer not to use the phaco machine to avoid any inadvertent opening of the posterior capsule. And then after completion of the phaco or the removal of the nucleus, a simple posterior rhexis, as you can see. As Dr. Nihal explained, we prefer to keep the posterior rhexis smaller than the anterior rhexis for future implantation if possible, limited anterior vitrectomy, and this includes the first eye. Of course, we put some sutures to make sure that the kid does not rub. Second eye surgery was similar. This is the video again. Viscoelastic. If you notice here, there is a bit of starting of the band keratopathy. Here, with just the rhexis forceps, we could identify this membrane. With the second eye, you get more experience. You could remove the membrane from the edge of the pupil, and then exactly what happened in the first eye, it's easier then to dilate. It's a little bit smaller than the previous eye, but we could manage to make rhexis. And then, because it is smaller, with the use of the spatula, you could push the iris away and start fishing for the lens quadrants and particles from behind the iris. Again, at the completion of the IA, posterior rexes with the size of a 4 millimeter, as advised by our colleagues and professors. And again, this concludes our surgery. This girl, you remember, she could see only 0.05 with both eyes, limited vitrectomy, and this concludes our surgery. So this is the picture of our EMR, the electronic medical records. Only 4 weeks post-operatively, she was left aphakic. So with a +13, she could see 0.7 in one eye and 0.9 in one eye. She had some flares and sense, of course, expected. But again, we reviewed her 1 year post-operatively, and she could still see 0.7 both eyes with minimal flare and cells or U. Thank you very much for your help, for your consideration.
Thank you very much, Ramy. Dr. Shama, do you have something to tell us? I understand that we ran out of time.
To the speakers from the audience. Dr. Nihal, there's a question asking about bagging the lens. Do you have any experience of bagging the lens in such cases?
I don't have experience with the lens. I don't think it's a wise decision. Bagging the lens means that you put the anterior and posterior rexes at the side of the lens. It's going to be like a sort of the lens will definitely going to touch the iris. There is no role of this technique even in congenital cataract. I'm not convinced that this approach neither applicable to congenital cataract and of course not applicable in cases of cataract.
A question for Dr. Ramy. In your case, if you leave the patient aphakic, do you prefer to make a wider rexus in such cases, or you do the same as in pseudophakic patients?
Well, we try to make not a huge rexus, 5.5 millimeters, and then the posterior rexus 4 millimeters, because there is always hope to implant. So there is always hope later on when the kid becomes an adolescent, for example, or a young adult, to try to open this bag again and implant the bag lens inside the bag, of the remnants of the bag.
Dr. Nihal, do you prefer a difference in the sizes of the capsular rexus if you leave the patient aphakic?
Yes, of course. If you intend to implant, the anterior rexus should be exactly 5. Why? Because the IOL optic is 6 millimeters. So it's going to be smaller than the IOL optic by 1 millimeter. And the posterior rexus should be 4 and not less. Because if you do it less than 4, definitely capsular phimosis will occur and secondary cataract will occur. Of course, coupled by anterior vitrectomy. There is no law to leave the anterior vitreous face intact. If you intend to leave the eye aphakic, no, you have to go for larger rexes. And they should be not less than 6 millimeters. Because less than 6 millimeters, capsular phimosis will ultimately occur, obstructing the visual axis, and you will need secondary surgical intervention. And even we can go for a larger than 6 because we are not going to ever implant in the future because it's going to be impossible to open the capsular bag, and if you want to implant, it will be in sulcus. It is contraindicated to implant in this axis. So it's preferable to be aphakic for the rest of the life.
Thank you. Dr. Mahmoud, في question لحضرتك. How do you manage hypotony after cataract surgery in patients with uveitis? Dr. Mahmoud, سامعني؟
Yeah, his connection is failing him.
The microphone is yours, Dina.
Okay, Dr. Shama, do you have any concluding remarks about the difficulty of uveitis cataracts? I think our
I
professors
have
have
a
shown
question
all
for
that.
you. Do you see
Okay.
patients with cataract due to abuse of steroids?
That's a very good question. So I can't really tell if what's happening is the inflammatory process or the steroids. There is the possibility of both. However, I have seen patients on difluprednate for such a long time that the patient presents like usually in kids with white cataract and high IOP. And this is definitely an abuse of the drops. But again, I always give the benefit of the doubt, so I don't really understand what's happening. But usually, when I see that, I always blame it on the drops.
So when you do stop topical steroids in a patient with uveitis?
Post-operative?
No. A patient with uveitis, he doesn't have any cataract, and you are following him. When do you stop the topical steroids?
So sir, we always, I mean, if the patient has a systemic disease or a posterior segment disease, we usually give systemic treatment. And if the systemic treatment, once it kicks in, because we understand that it takes about 3 months for its full effect. Once the 3 months have passed, we can slowly taper the topical steroids. And if the patient stays with, sits with half plus cells in a chronic patient, half plus cells, I will tolerate that. I would tolerate half plus cells with a drop every other day. I would tolerate that. So every patient is tailored really according to their condition. But I would usually go to maximizing systemic methotrexate or azathioprine rather than giving topical.
Okay. What about patients with flare? If you find a patient with chronic flare?
So we expect to see flare in chronic patients like in JIA or VKH, and we don't like flare at all. Although patients sit with flare, but we don't like it because we fear that it means that there's a disruption of the blood aqueous barrier, which means the more pouring of proteins and more possibility of forming synechiae. So we like really to put those patients on cycloplegics. According again to the visual demand, like for kids who are going to school, we usually keep them on once a day. If we need more, then we do more in one eye and less in the other eye. You always have to balance according to the visual demand of the patient. But if you keep a patient on 1 drop a day of cyclo or any cycloplegic, then that would work well. And usually we give it at bedtime. So by the time the patient wakes up and starts to resume their work, the effect has gone. The cycloplegic effect has gone.
Great. How can you, this is for all the panelists, how can you manage cystoid macular edema post-operatively?
Dr. Nihal, what's your preferred practice?
I don't treat cystoid macular edema. I refer to you, Dina.
That's actually true. Okay, Ramy?
I told you I do the easiest part, which is the surgery, just the surgery, and I leave all the medications for you.
That's
We
true.
actually do the same. We refer them back to the practice clinic. And we tell them those patients develop macular edema post-cataract. So please advise.
Okay.
Another question, when do you expect hypotony? In the preoperative examination, how can you expect hypotony? Dr. Nihal.
In cases which I see the cases of hypotony that I should expect the JIA, all other types are treatable. But the JIA, it's a sort of a monster. So the younger the age, if I'm going to implant or I'm forced to implant in JIA, if I have severe cases with complications like together with the cataract, I have a posterior synechiae, I have an iris bombay, I have a secondary glaucoma, I'm going to go for too much manipulations. I expect that after surgery, and of course, if I have fibrosis of the anterior capsule and expected to have a sort of a cyclitic membrane, I should expect that after surgery, I'm going to have this hypotony. Unless he removes totally the posterior capsule and the fibrosis, we should expect that there's going to be a sort of a ciliary body shutdown. Of course, sometimes with repeated surgeries, when you go for example, membranes, and you want to remove these membranes, and you go for a second surgery or even a third surgery, it ends up with a hypotony and sometimes intellectual.
To Ramy, when do you refrain from surgery إذا كان intraocular pressure قد إيه؟ تقلق من preoperative intraocular pressure of what? What's the number that you're afraid to operate?
يعني اقل من 10 9 الواحد بيبقى مش يعني بيبقى يعني قلقان، وبالذات زي ما I think دكتوره نهال قالت انه بالذات لما يكون في ايرس بومبي او في severe inflammation يعني secondary closed angle glaucoma والintraocular pressure مش عالي، دول انا بقلق منهم جدا.
Yes, this is a point. When you have a normal intraocular pressure and الطبيعي and it should be extremely high.
Yes.
You have an occluded angle, and you have very shallow chamber, and then you find the pressure within normal range.
بقلق قوي منهم دول.
Dina, I will get the microphone for you to conclude the session. Okay. But I'd like to thank all the speakers. I'd like to thank Professor Mahmoud Soliman, Professor Nihal Al Shakankiri, and Professor Ramy Riad. I can't thank you enough, Dina, for your effort and for your management of our patients. I'd like to thank you so much. You made a difference in iCare.
Thank you, Dr. Shama, very much for your kind words and for being with me, for supporting me in cataract surgery on this episode. Dr. Nihal was the one who recruited me in Alexandria. So thank you, Dr. Nihal. She actually picked me and decided I should start seeing patients in Alexandria. Ramy Riad is my cousin, my good friend, and he puts a lot of trust in me. Dr. Mahmoud Soliman always teaches us about posterior segment and uveitis. So thank you all for being with us. Thank you to our listeners for being with us all this time. Thank you to RM, and have a good night, and we wish you the best of luck with those difficult patients.
شكرا جزيلا.
Thank you very much for the invitation. Bye.
صباح الخير.